diseases. Okay, Dr. Sim, you understood, no, about that, about Page's disease? Okay, now tell me, what are the hormones secreted by the pituitary gland? Everybody know, no, pituitary gland. So pituitary gland has how many parts? Two parts, no, anterior, posterior. Anterior pituitary, how many hormones it will synthesize? How many hormones? Screen is not visible. Uh, screen is not visible. It is visible. Can you please rejoin? Screen is visible. Yeah. Okay. Okay. See, pituitary gland has two parts: anterior part, posterior part. Anterior part, how much? How many hormones it will synthesize? Anyone? Just guess. How many hormones? How many hormones? How many hormones it will synthesize? I need number. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. How many hormones? Anterior pituitary. Very good. 6 hormones. Very good. So 6 hormones. What are they? Growth hormone. Okay. And yes, you are right. TSH. Thyroid को stimulate करने वाला. Thyroid hormone. Then we have mammary glands को stimulate करने वाला. PRL. Prolactin. Then we have gonads को stimulate करने के लिए. FSH and LH. And the last hormone to adrenal gland. Adrenal gland को stimulate करने वाला. ACTH. Okay, from top to bottom, these are the 6 hormones synthesized and secreted by anterior pituitary. Now, what are the hormones synthesized by posterior pituitary? The answer is 0. Posterior pituitary do not synthesize any hormone. Posterior pituitary only store hormone and it will secrete hormone. Hormones, actually the hormones will be synthesized by hypothalamus. For those, ADH and oxytocin. Okay. Now we will go a little fast now for endocrine. And endocrine, we have worked very hard to make the notes of these endocrine diseases. So just focus, and we will be sharing an amazing notes with you. If you want to write it down, please write it down. Okay. Now we will start with first growth hormone. So problems, growth hormone. Growth hormone के problems. Growth hormone, excess of growth hormone. If excess of growth hormone occurs in children, what is that known as? Child का. Excess of growth hormone occurs in children. What it is known as? Gigantism. ठीक है? Gigantism. Gigantism. ठीक है? Children का. If excess of growth hormone occurs in adults, so A for adults, A for acromegaly. Excess synthesis of growth hormone in adults. Okay, this is how you remember. A for adults, A for acromegaly. This is the definition of acromegaly. Now, how many of you know ki growth hormone ki functions? What are the functions of growth hormone? Anyone? Just guess. Functions of growth hormone. Okay. Tell me whether it will increase the blood glucose level or decrease the blood glucose level. No problem. Just increase or decrease. You type increase or decrease. Yes, you are right. It will increase the blood glucose level. Okay. So growth hormone. Why there is excess of growth hormone in adults? See, the main etiology lies here in two reasons. One is there is a tumor in pituitary gland, and that tumor is known as adenoma. Pituitary adenoma. Okay. If pituitary adenoma is there, then excess GH secretion can occur. This is the almost 90% cases we see pituitary adenoma. There are some rare reasons. The rare causes of pituitary this hypersecretion of growth hormone is the growth hormone is hypersecreted because there is hyper stimulus by the growth hormone releasing hormone from hypothalamus. So actually the problem is in hypothalamus. So more GHRH is released. That's why more GH is released. Okay. So this is the rare cause. Rare cause. Another rare cause is there is no problem in the pituitary, nor the problem is in the hypothalamus. The problem is in the lungs. So we have SCC, small cell lung carcinoma. Small cell lung carcinoma. In SCC, the paraneoplastic syndrome is excess growth hormone. Okay. So this tumor will secrete excess growth hormone that will be manifested as acromegaly. So how will the patient present to you? With apes growth. This is the mnemonic apes growth. Apes growth, GROWTH. Apes growth is a mnemonic. Remember A for arthralgia, excess joint inflammation leading to joint pains. Then prognathism, excess bony growth. This is protrusion of the jaw. Protrusion of the jaw is prognathism. More sweating is there. Thick skin will be there, and that thick skin will compress the underlying nerves, leading to carpal tunnel syndrome. Growth, excess growth of hands and feet. The respiratory changes will be there because of chest wall expansion problem. Organomegaly will be there, but remember, even though organomegaly is there is loss of libido. Even though testicular enlargement is there, but there is loss of libido. Menstrual irregularities will be there. Okay? So this is about that. Widened nasal brace, tongue enlargement. This is important. Tongue enlargement. Tongue enlargement only said in acromegaly. Tongue enlargement, headaches due to skull growth. Apes growth is a mnemonic. Patient presented with following symptoms. Apes growth. Okay. This is the clinical presentation. How are you going to diagnosis? How will you diagnose this condition? First, for diagnosis, if the patient presenting with any apes growth, any of the symptoms, you look for you screen first. You look for something known as marker. What is the marker of growth hormone? You cannot directly measure growth hormone, so you measure the marker of growth hormone, that is IGF-1. So if IGF-1 levels are more, it means growth hormone is more. So this is a marker. So this, but if you want a confirmatory test, what you can do is OGTT, oral glucose tolerance test. Now, how OGTT will help you understand whether growth hormone is more or not? So we will write in normal patients, whenever you give, glucose. In normal patient, whenever you give glucose, like you ask them to give drink glucon-D, so that will increase glucose levels in their blood. Whenever you give a glucose load to the patient, this will instantly this will decrease GH levels. Instantly it will decrease. Okay. But in cases of acromegaly, in spite of giving high glucose, growth hormone level will still remain high. Okay. So this is an abnormality that you pick up. This is the confirmatory test is OGTT. Now you confirmed that the patient has an excess growth hormone. Now you want to know the cause. Okay. To know the cause, what you can do? MRI brain, MRI pituitary gland. That's how you are able to find out about the tumors, pituitary tumors. So adenoma or hypothalamic tumors can be found out by MRI brain. If the patient has some metal implant and can't get MRI, do CT scan, but do some imaging, brain imaging. How are you going to treat this condition? Treatment. How are you going to treat anybody? There is excess growth hormone, no? So you give, what do you want to do now? Growth hormone blockers you want to give? Are there such things? Blockers? No, no. What do you want me to repeat, Yogita? I'll repeat again. See, what is acromegaly? Acromegaly means growth hormone excess in adults. Okay. So what is there? If in normal patient, whenever you give glucose, whenever you ask the patient to drink glucose load, that is a glucon-D, so their blood glucose will rise. So whenever the blood glucose will rise, growth hormone should decrease. But in patients with acromegaly, whenever you give glucose, growth hormone will still remain high. Okay. That is what. Okay. So this will confirm कि this is not a normal GH, this is an abnormal GH, this is excess GH. ठीक है. Make it very simple. I'll repeat again. See the procedures that you follow for OGTT. In OGTT, you first take the resting blood glucose level, RBS you take, and you take the resting growth hormone level. Then in the second step, you ask the patient to drink Glucon-D. Okay. Glucon-D consists of a lot of glucose load will be there in Glucon-D. In third step, after waiting for 30 minutes, that depends. Okay. You take readings. So in readings, you check what will you notice? There is increased RBS. And normally, if RBS is increased, meaning blood sugar levels are increased, it means GH should decrease normally. But in patients with acromegaly, GH will still be high. Okay. So this is how you infer that this is the patient of acromegaly, and you will know the cause. How are you going to treat this patient? You can treat this patient by blocking. You cannot block growth hormone. You cannot block. What can you do? You can there are no anti growth hormone you cannot give. You can give something known as to decrease its secretion from what, from pituitary. So give somatostatin. Somatostatin, whether it can be artificial or natural somatostatin. What is the best example of somatostatin? Octreotides. Okay, octreotides. Another thing that you can do is, if the growth hormone is secreted, first you block secretion. Even if it is secreted, you block its action. You block its action. How are you going to block the action? You give GH receptor antagonist. Best example, pegvisomant. pegvisomant. तो दिस इज द मेडिकल ट्रीटमेंट भाई. क्या करना है? ग्रोथ हार्मोन या सिक्रीशन को भी कम करो, या फिर यू ब्लॉक इट्स एक्शन. Decrease secretion. Best example is octreotide drug. Decrease its action. Pegvisomant. Rarely, what it is found is in especially in hypothalamus and in brain, if you increase dopamine levels, growth hormone is inversely proportional to dopamine levels. So if you increase dopamine levels, growth hormone will automatically fall. So that is one hypothesis. So in resistant cases, you can also give dopamine agonist. So this is the concept behind it. Okay, no problem. If you don't want to write also, just write this: decrease secretion, decrease action. The definitive treatment will only happen when you remove the tumor. So for removing the tumor, you need surgery. So which surgery is performed here? Which surgery is performed to resect that this pituitary tumor? You approach it through with the nasolabial fold, and that surgery is known as transsphenoidal surgery, because pituitary is in the sphenoid, no? Transsphenoidal surgery. Transsphenoidal surgery. After surgery, always remember to give patient radiotherapy, because pituitary adenomas recur. They have high chance of recurrence. That's why after surgery, always radiotherapy is followed. Okay, acromegaly over. Acromegaly. Acromegaly. Any doubts in acromegaly? If you have understood, raise your hands. Yeah, Zabardast, Zabardast. Okay, okay. Chalo, chalo, Zabardast. Now, from now, okay, all the endocrine topics we have categorized into some tables. Okay, some tables. So we have tried our best to summarize this. So we have created few tables of most commonly misunderstood topics, to and that too those topics are very repeated. So students, they DM us and they'll ask, sir ये आए तो क्या लिखना, थायरोटॉक्सिकोसिस में क्या स्पेसिफिक है, व्हाट इज द स्पेसिफिक फॉर ग्रेव्स डिजीज, सब सेम दिख रहा, सब सेम दिख रहा. ठीक है. So we have created tables, and these tables, if you utilize it carefully, it is going to change your life. ठीक है. Zabardast, you have to follow step by step. We will write it down. So what is hyperthyroidism? What is hyperthyroidism? Hyperthyroidism occurs because basically it means there is more activity, increase the activity or overactivity of thyroid gland. Okay? Overactivity of thyroid gland. This is hyperthyroidism. So what could be the cause? The cause could be a problem, a primary cause. Primary cause meaning a problem is in the thyroid gland. Okay. What could be the problem in thyroid gland? That thyroid gland may have a adenoma, benign tumor, or it might have something known as grave disease, which is something of malignant condition, or it can have a multinodular goiter, MNG. This is the primary cause of hyperthyroidism. What are the secondary causes? Secondary causes means the problem is not in the thyroid, problem is somewhere else. The best example is some TSH secreting pituitary adenoma is the problem. Meaning from pituitary it excess TSH. That what does TSH do? Thyroid stimulating hormone. So it will stimulate more. So more stimulation, more activity of thyroid gland. So this is a secondary cause. Okay. Over hyperthyroidism, what is definition? Etiology. Now what happens in hyperthyroidism? We see more of thyroid hormones. Okay. So I'll tell you thyroid ka, I'll tell you. See basic funda, what you have to remember is from pituitary comes TSH. Okay. What does TSH will do? TSH go and it will stimulate thyroid gland. Okay. So this stimulated thyroid gland will release lots of thyroid hormone. So what are those? It can be either a T3 or a T4, some iodinated hormone, T3, T4. So this T3 and T4, they'll go and they will block this TSH. TSH. They will block the TSH secretion. So this is a feedback mechanism. Okay. Now you tell me, if TSH is more, what does it mean? If TSH is more, what does it mean? TSH is more. It means TSH is not getting blocked. Why it is not getting blocked? Because thyroid hormones are no. Okay. So TSH is more is a marker of hypothyroidism. So TSH more means it is hypothyroidism. Okay. If TSH is high, sorry, if TSH is low means TSH is low, meaning feedback inhibition is very well working, meaning it is hyperthyroidism. Okay. Hyperthyroidism में TSH will be low. So this will be opposite. TSH is a marker, you just remember that. Okay. So pathophysiology, what is happening? More thyroid hormones and they will inhibit TSH. So in TSH levels will be secretion, TSH levels will be low. More thyroid hormone, increase the BMR. Basal metabolic rate of the body increases. Basal metabolic rate of the body increases because of excess thyroid gland, thyroid hormone. So main features, what will be there? More metabolism. More metabolism means what? More metabolism means, like for example, if you are eating a burger, it will be metabolized, into some products, into some it will be metabolized, it will be digested, it will be utilized. So if that metabolism is more, means you even if after eating 10 burgers also, you will not gain weight. Okay. So the main features of hyperthyroidism is weight loss. Main features are hyperthyroidism, weight loss, and they'll be very hot. Okay, hot to touch. Their cardiac system will perform more, leading to tremors, some palpitations will be there. Palpitations, more heart rate. Okay. Their CNS will work more, leading to anxiety. They will have tremors. Basically, metabolic drive बढ़ जाती body. Okay. Thyroid enlargement, yes, you can be able to appreciate some goiter depending on the cause. If it is a primary cause, yes, of course, you can appreciate a goiter. Ophthalmology, meaning what? Ophthalmopathy will not be there. There will be no problem in the eyes. Okay. Usually, hyperthyroidism, isolated hyperthyroidism, there will be no problem in the eyes. How will be the skin? Already told you, skin will be warm. Warm skin and moist will be there because this warmness the sweat agar aa gaya, so moist will be there. How are you going to diagnose? In thyroid function test, you will see only two things. There is increase in levels of T3 and T4. But TSH will be low. Low TSH. Okay? Low TSH. This is how. Now, comparing this with thyrotoxicosis. What is thyrotoxicosis? Thyrotoxicosis बोले तो here same elevated thyroid hormones, but it will cause the cause same elevated thyroid hormones, but the cause is different here. The cause is either due to inflammation, either due to inflammation. What is the cause? The cause is either due to inflammation of thyroid gland or due to some exogenous thyroid source. Meaning hyperthyroidism patient taking thyroid supplements. So exogenous thyroid source. Because of this, the body goes into hypermetabolic drive. Again, okay. What is thyrotoxicosis? This is toxicosis. Why it is toxicosis? Because here thyroid hormones were already low, were already more, but there is some inflammation, and it could also be due to some exogenous thyroid source. Because of this, more increase in thyroid hormones occur. Okay, followed, no? Yes. So the onset of hyperthyroidism is usually gradual onset. Gradually it will increase, gradual onset, but yes, sudden onset will be there because she consumed some thyroid tablets. Hyperthyroid case, she consumed some thyroid tablets. So suddenly it will increase. That is known as thyrotoxicosis. Okay. So symptoms will be severe here because suddenly it will increase. So same symptoms will be there, but it will be severe. Severe means what? Here palpitations are this. There will be arrhythmia. Severe symptoms. Thyroid enlargement? No, it will not be there thyroid because it is acute condition. No thyroid enlargement. Yeah. Ophthalmopathy? No, it will not be there. How will be the skin? How will be the skin? Anybody? Same. Warm, moist skin will be there. Okay. Thyroid function test? Anyone? Thyroid function test? Elevated T3 will be there, elevated T4 will be there, yes, but TSH, the TSH level can be normal or low depending on kitta time hua. Just now she took means the TSH will be normal, but some time has passed, like 2-3 hours have passed, then TSH will be low because T3 and T4 they take time to go to the pituitary and take time to suppress the TSH. Yes, yes, somebody has raised hand. Yes, what is your doubt? 33. Okay, I'll repeat again. Hyperthyroidism, simply more activity of thyroid gland, and it has gradual onset. It has gradual onset. Okay, gradual onset. It has gradual onset is hyperthyroidism. Okay, gradual onset is hyperthyroidism. Gradual onset. Okay, gradual onset is hyperthyroidism. Sudden onset is thyrotoxicosis. Sudden onset is thyrotoxicosis. Okay, sudden onset. Now, grave disease. What is grave disease? Destruction. Destruction of thyroid gland by autoimmunity. So, autoimmune disorder it is. So, in this autoimmune disorder, what is happening? In this autoimmune disorder, there is TSH receptor. On the TSH receptor, antibodies are being formed on the TSH receptor. So what will happen? Continuous stimulation of TSH receptor will occur. Okay? Continuous stimulation will occur, leading to this. All this, so it will be the onset will be gradual here, and it has same clinical features plus thyroid enlargement, ophthalmopathy will be there. So these are the characteristic features of grave disease. Okay, followed, no, everyone. Grave disease. What a difference between hyperthyroidism, thyrotoxicosis, grave disease. How are you going to treat now? Anything? Yes, in skin. Yes, also remember in skin. One more point I forgot: the myxedema, pre-tibial myxedema. Very familiar with. What is this? Myxedema, grave disease. So grave disease has myxedema, ophthalmopathy, exophthalmos that we say, and pre-tibial myxedema. In function test, thyroid function test, what are you going to notice? Yes, anyone? The same test, but you will also notice TSI antibody. Okay. TSH receptor antibody is TSI antibody. TSI antibody will be positive because it is an autoimmune condition. Okay. So this is an advanced test actually. What is a active iodine uptake? That depends. If the thyroid gland is hyperfunctioning, so uptake will be more. So here, that depends. Normally, if it is an acute condition, it can be normal, or just 2-3 hours have passed, so it will be more. That depends. Here, normally increase, grave disease uptake is increased, iodine uptake is increased. Okay. What are the treatment options? You give anti-thyroid medications in hyperthyroidism. Plus, if anti-thyroid medications like carbimazoles and all, they are not working, you can give radioactive iodine, or if they are not working, prefer for surgery, thyroidectomy, either partial or total, depending. For this condition, thyrotoxicosis, the problem here is the severity of the symptom. Thyrotoxicosis, the problem is in the severity of the symptom. So you just can't give anti-thyroid drugs. Anti-thyroid drugs, they take time to work. So your main goal of treatment will be on symptomatic treatment. So what are the symptomatic treatments here? For CVS, what was the problem in CVS? Increased heart rate, palpitations were the problem. So you give beta blockers. Beta blockers. So if the cause is the inflammation, so you give steroids to suppress the inflammation. Then you start the patient on anti-thyroid drugs. Anti-thyroid drugs. Okay. So this was the management for thyrotoxicosis. Now grave disease, what will you do for grave disease? What will you do for grave disease? Same anti-thyroid medications plus radioactive iodine. Or if they are not responding, then you can steroid. You can put them on steroids, or you can do surgery if the goiter is very large. Okay. This is about the thyroid hyperthyroid disorders like hyperthyroidism, thyrotoxicosis, and grave disease. Everybody understood? No? Understood. No? See here, main difference is here: the gradual onset of hyperthyroidism and the sudden onset of thyrotoxicosis. Okay. Okay. Those who have understood, please raise your hands. Zabardast. Okay. 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 Now we will talk about the hypothyroid conditions. The three similar hypothyroid conditions. So here again, hypothyroidism. What will you notice? Hypothyroidism. Underactivity, decreased activity of thyroid gland. Underactivity, you will notice. Underactivity of thyroid gland. What is mixed edema? Mixed edema means it is a counter equivalent of thyrotoxicosis. So here there is severe form of hypothyroidism in which total body edema is seen. Okay. Total body edema, severe form of hypothyroidism. Okay. What is Hashimoto? Again, it is the counter equivalent of grave disease. So it is an autoimmune disorder. But in this autoimmune disorder, the problem which arises is lymphocytes. Lymphocytes, they will penetrate the thyroid gland and they will eat up the thyroid follicles. So lymphocytic infiltration occurs. Okay. So lymphocytic infiltration, that's why the thyroid hormones levels will decrease. So what is the etiology of hypothyroidism? Hypothyroidism, again, it could be primary. Primary means problem is in the thyroid gland. So the best example is Hashimoto, primary. Hashimoto thyroiditis, autoimmune condition. Or it could be secondary reason, meaning problem is not in the thyroid gland is normal, but the problem is if the patient is not taking iodine deficiency. Okay. Best example. या फिर patient doesn't have thyroid gland, post-thyroidectomy. Okay. So when typically middle-aged females, the age of onset is typically middle-aged females, and here the symptoms opposite to that of hyperthyroidism. What are they? Here weight gain will be there because BMR will decrease. So whatever you take, whatever even if you eat one burger, it will not be digested. That's why weight gain will be there, gaining of weight. Patient will have cold skin. Patient heart will be very heart rate will decrease. That is bradycardia will be there for the patient. Bradyarrhythmias. Even if the patient is not getting digestion because of constipation, everything will slow down. Everything will slow down. Okay. So CNS में what will happen? Patient might be feeling about lethargy, not able to do anything, fatigue, everything will slow down. In hyperthyroidism, anxiety, tremors were there. That is hyper activity of CNS. This is hypoactivity of CNS leading to lethargy, fatigue. Okay. So this is the hypothyroidism case. Now mixed edema, what will happen? Mixed edema. What is mixed edema? Mixed edema, what is the etiology? This severe form occurred because of untreated hypothyroidism. Untreated hypothyroidism. Okay. Because of this severe edema occurred. So age of onset most commonly seen in older females. Older females who miss their thyroid drugs, thyroid medications. If they don't take for almost 1 to 2 months, they will be having mixed edema. So what is the key symptom in mixed edema is they will have edema on the face, edema around the orbit, periorbital edema. And because of that edema, it will compress everything. Even the heart get compressed, leading to low cardiac output, that is hypotension. Okay, everything. She will not talk properly. Severe lethargy will be there. Severe lethargy. Severe lethargy means they'll sleep. They'll continue sleeping. Like severe lethargy. This is about mixed edema. What is Hashimoto? Hashimoto, what was the case? Yeah, lymphocytic infiltration was there. Okay, so etiology may lymphocytes, they will invade the thyroid follicle, they will destroy the thyroid follicles. So how they will destroy the thyroid follicles? By forming antibodies against the follicles. Antibodies, they attack normal thyroid tissue. Okay. Age of onset, especially middle age, and that too female. Why female, sir? Because autoimmune condition. All autoimmune disorders are common in females. Key symptoms same here. Here same same hypothyroidism features will be there, hypo wale. But remember, there will be a goiter. There will be a goiter. Why, sir? Why goiter? Because lymphocytes are infiltrating. No, so they will infiltrate. Then they will cause a swelling in the thyroid gland, leading to goiter. Swelling will be there, goiter, and that goiter may have some pressure wale symptoms, hoarseness on the voice, dysphagia, etc., etc. So this is about Hashimoto. Okay, the main signs, what could be the signs? This is about this. Yeah, they will be having, most important, dry skin compared to moist skin in hyperthyroidism. Here skin will be dry. Skin will be dry. What about mixed edema? Mixed edema, they have puffy skin, puffy swollen wali skin. Okay. Oh, because of edema, and that puffy swollen skin might turn yellow. If it is a chronic case, it might turn yellow. Here, yeah, already talked about goiter. Goiter might be there, and what else? That goiter can be nodular goiter also. So the complications can be because of some pressure symptoms, dysphagia could be there here. And here the complications could be because of severe lethargy. CNS might shut down. This is known as coma. So this is mixed edema coma. Mixed edema coma, we say. CNS might shut down. So respiratory failure can occur in this condition. This is because of mixed edema. Mixed edema, very severe condition, severe form of hypothyroidism. So here hypothyroidism normal hypothyroidism, what could be there? Fat metabolism is inhibited. Like it will is very low, so it will accumulate cholesterol. This cholesterol accumulation might cause atherosclerosis, leading to CAD, coronary artery disease. Okay. So lab may, what will you do? What will you notice here? Low level of T3, low level of T4, and how will be the TSH? TSH will be elevated. High TSH will be there. High TSH. So here also same. But here very low levels of very severe, like very low levels of T3, very low levels of T3, and very high levels of TSH. Yeah. What about this, sir? Hashimoto. Hashimoto में actually क्या होता? In the initial stage, it will have some like normal to low levels of T3, T4. And after that, in the final stage, it will be same. It will be same. Okay. Plus, it will have antibodies. So what antibodies will be there? Specific to Hashimoto, we have anti-thyroid peroxidase antibody or anti-thyroglobulin antibody. So anti-TPO is specific for Hashimoto. So antibodies detection can be done in the lab. How are you going to manage? Replace thyroid replacement. Thyroid depending on how much is mg, 25 microgram, 125 microgram. That depends. So here, what do you want to do here for mixed edema? Mixed edema, IV replacement of thyroid immediately. IV thyroid replacement plus supportive care. Like if airway is compromised, manage airway, breathing, circulation, the supportive care you do. Here, what you do for Hashimoto, since it is autoimmune condition, total thyroid gland is lost, total thyroid gland is infiltrated by lymphocytes. So you give lifelong replacement of thyroid. Okay? And then regularly you monitor TSH levels to check whether she is in hypo state or hyper state. Okay. What is prognosis? Normally good ही रहेगा यहाँ का, high just isolated है, but remember high mortality is seen in mixed edema. High mortality. Okay. So this is about what is this hypothyroid. So thyroid disorders. Any doubt in thyroid disorders? Thyroid disorder, any doubt? Hypo, mixed edema, Hashimoto. So if you just remember this table, you will be able to write all, you will be able to cover these three questions: hypo, mixed edema, and Hashimoto. And this is also, hyperthyroidism, thyrotoxicosis, Graves' disease. Understood? No? You followed? Okay, 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 very good. Now we will come to adrenal disorders. Okay? Disorders of adrenal gland. Yes, disorders of adrenal gland. What is Cushing? Anyone? What is the difference between Cushing disease, Cushing syndrome? Cushing disease, Cushing syndrome. Cushing disease means the problem is in pituitary. Okay. Cushing syndrome means the problem is in adrenal gland. So Cushing syndrome. What is Cushing syndrome? Cushing syndrome. The main. What is the definition? Here it is a clinical syndrome characterized by high cortisol levels. So high cortisol levels in Cushing syndrome. What could be the cause, sir? The cause high cortisol could be because of adenoma. Pituitary से secretion ज़्यादा आ रहे. So adenoma. Pituitary adenoma. ठीक है, pituitary adenoma. So maybe this adenoma is producing ACTH, and that ACTH is causing increased cortisol levels. Okay. Or if pituitary adenoma is not there, then adenoma might be in adrenal gland. Adrenal adenoma might be there. Adrenal adenoma that is increasing cortisol synthesis. Okay. या फिर if it is not there, the patient might be injecting steroids. The patient might be injecting steroids exogenously, especially the wrestlers. Or if it is that is also not there, the last is paraneoplastic syndrome, especially small cell lung cancer. Small cell lung cancer, apart from secreting GH, it also secrete this cortisol level, ACTH. ACTH it will secrete. That ACTH will increase the cortisol levels. Okay. So these are the main four causes for Cushing syndrome. Cushing's. What is Cushing? It is a clinical syndrome in which cortisol levels remain high. Okay. We are going very slow because we don't want you to confuse between these topics. Okay. Okay. So what are the primary symptoms? Cushing क्या करेगा? Cushing will increase blood glucose level because it is a stress hormone and you need glucose to fight with the stress. So it will increase the glucose level. So again, if you increase glucose level, what will happen to your weight? It will cause weight gain. Weight gain. What will happen to your BP? It will increase your BP. Hypertension. And you will be obesity. And how will be your muscle? It will catalyze the proteins to increase glucose level. Protein breakdown will happen. That's why muscle weakness will be there. Okay. So main Cushing features are this. What will happen to your skin? The skin will have what is that known as purple striae. Striae will be there. Basically, it means the skin is very thin and it will get bruised easily, easy bruising, and purple striae might be there on the abdomen. What will be, yes. So this is about Cushing. Now we'll talk something about Addison's. What is Addison? Addison's disease. Addison disease is a condition where there is low levels of cortisol and aldosterone. Okay? Low levels of cortisol and aldosterone. So basically we say Addison is a disease which basically means there is adrenal insufficiency. Adrenal gland is not functioning properly. In Cushing syndrome, adrenal gland is hyperfunctioning. But in Addison's disease, adrenal gland is not functioning properly. Why it is not functioning, sir? What could be the reason? See, the reason could be number one. Okay. The reason could be autoimmune destruction of adrenal gland, especially adrenal cortex. Autoimmune destruction. Okay. Autoimmunity. Primary cause is autoimmunity. Or if autoimmune is not destroying, some infections might be destroying the adrenal gland. So which infections will destroy adrenal gland? Sir? TB. Okay. Or if infection is also not destroying, blood might be ruptured in the adrenal gland. That is hemorrhage might happen. Adrenal hemorrhage. Adrenal hemorrhage. Or congenitally the problem is there. Congenital adrenal hyperplasia. Congenitally adrenal gland is not functioning. So these could be the four causes of Addison's disease. Addison's disease. So what will happen, sir, now? There is low cortisol here. So low cortisol. See, high cortisol was doing weight gain. So low cortisol should do weight loss. No? Okay? Weight loss will be there. Obesity will not be there. Muscles will not be active here. Here weakness will be there. Why? I'll tell you why. Because low cortisol, no glucose in the blood. No glucose will be muscle, will be weak. Okay. How will be the blood pressures are here? Hypotension. Hypotension is common. Hypotension. Okay. What about the skin cell? See here, the problem in Addison's disease is, see, I'll tell you, ACTH was coming from the pituitary to release adrenal, it will act on adrenal cortex and release all the adrenal gland hormones. After releasing this cortisol or aldosterone, they will go and they will inhibit this as ACTH. So now tell me, if adrenal cortex is not functioning means there is no inhibition, means there is high levels of ACTH. So this ACTH hormone has some melanocyte stimulating activity. So that's why here in Addison's disease, ACTH will be more. So due to increase in ACTH level, they will stimulate melanocyte more. That's why pigmentation might be there here. Pigmentation, especially pigmentation because of ACTH hyper. Now tell me. Now, electrolyte imbalances. Okay, before going to electrolyte imbalances, I would like to tell something about pheochromocytoma. Pheochromocytoma is a different condition. These two conditions were due to were in the adrenal cortex problem. Pheochromocytoma is the adrenal medulla problem. The adrenal medulla problem. So here, this is a tumor of adrenal medulla. Okay, tumor of adrenal medulla. So what it will do? What was adrenal medulla doing? It was releasing catecholamines. Now the tumor is there, so it will release excess catecholamines. Epinephrine, catecholamines. It will release excess catecholamines. Okay, so what could be the cause, sir? Causes mostly isolated tumor of adrenal medulla, or it could be a part of syndrome. So which syndrome contains this pheochromocytoma? MEN2. Okay, MEN2 adrenal pheochromocytoma MEN2. So what is happening here? Hyperactivity of CNS, vasoconstriction. Okay, what is happening? Catecholamines में hyperdrive in the CNS and vasoconstriction. Due to this, what is the primary symptom? If vasoconstriction occurs in the head region, so headache might happen, palpitations might happen, severe hypertension can happen. Okay? And because of this, they will be having sweating also. Okay? Sympathetic nervous system is there, no sympathetic nervous system to the sweat glands, and why sweating might happen. So how will be the BP? Hypertension. So BP will write with red. So BP will be hypertension. How will be the skin here? Your skin will be pale. Why, sir? Why pale? Because vasoconstriction is there. Okay, vasoconstriction, skin will be pale. Now we will go into the, we'll dive deep into the, are you going to know what electrolytes will be disturbed here? See, I'll tell you one more. Aldosterone, if it was there, aldosterone used to do what is known as सोडियम का reabsorption or potassium का excretion normally. Now aldosterone is not there in Addison's disease. What should happen? What should happen? Sodium should be lost in urine, so there will be hyponatremia. Okay? And potassium should remain, okay, in the blood, leading to hyperkalemia. Okay? Hyperkalemia. Okay, so this is about Addison's disease. Addison's disease. Okay. Now about Cushing's. See, Cushing, what it was doing, it was increasing the blood glucose level. So increasing in blood glucose level will also trigger insulin, and because of that hyperglycemia, it will cause hypokalemia. Okay, insulin glucose, hypokalemia. What about pheochromocytoma? Pheochromocytoma, where normally there will be no electrolyte imbalance. No electrolyte imbalance. The only imbalance that you will see is due to hyper drive, there will be hyperglycemia might be seen. Okay, that is the only thing that you will find here. So about the mood, yes, obviously mood here. What will happen? Yes, due to this obesity and all, they'll be very irritated. Irritability will be there. In Cushing's, irritability will be there. And about here in Addison's, nothing is there. So apathy, they will not show any symptom, and they'll be depressed. And here they will be very anxious because hyperdrive, anxious, panic attacks, all those things are seen here. About the glucose, here glucose will be high, here glucose will be low, here glucose will be high. Okay, already talked about cardiovascular effects, no needed again. So this is how you diagnose. How are you going to diagnose for this patient? You will check for cortisol level. For how long you check? 24 hours. Where do you check? In the urinary. So 24-hour urinary cortisol will be increased. Okay. So this is how you diagnose Cushing's. Cushing's. So here what you check? You check for cortisol. Cortisol will be low. You check for aldosterone. Aldosterone will be low. But when you check for ACTH, ACTH will be high. So this will confirm. What it will confirm? Addison's disease. Pheochromocytoma, you check for catecholamines. So the increase catecholamines, whether you check in the urine or in the serum. If you check in the urine, catecholamine excretion products will be more. So what excretion products are there? VMMA, metanephrines. Okay. They will be more excreted in urine. This is how you diagnose. Treatment, you know already. Cortisol treatment. What is there? Cortisol treatment. Because why it is happening, you should know. What was the reason? Adenomas, no adenomas. So you give surgery. Okay, surgery. Or you can also give anti-cortisol medications. So some antifungals we have ketoconazole. They have been found to block this, inhibit cortisol synthesis. Ketoconazole. Here replacement therapy in Addison's, replacement therapy, and here pheochromocytoma surgical removal. That is the mode of treatment for all this. So Cushing clear. Cushing, Addison's, pheochromocytoma. Adrenal disorders clear, everybody? Clear? How many of you understood? Just raise your hands. Yes, I'm trying to be as fast as possible. Okay. Cushing, Addison's, pheochromocytoma. Okay, very good, very good. Zabardast. Okay. Okay. Now, last. This will be my last. Okay. DM, DI, and SIADH. So, what is diabetes mellitus? See, mellitus matlab, what is mellitus? Why it is named as mellitus? So in olden days, they used to, they used to diagnose the people. They used to diagnose the condition by tasting the urine. I know it sounds gross, but by tasting the urine of the patient, they used to diagnose their diabetes. Okay. So mellitus refers to meatha. Okay, meatha. So such why the urine is meatha, because urine contains glucose. That's why it is meatha. So that's why it is named as diabetes mellitus. Insipidus means khatta. Okay. Tasteless. Tasteless. Why tasteless? Water is tasteless. So their urine is purely water. Their urine is not severely diluted urine they will be having. SIAD. SIADH means syndrome of inappropriate ADH secretion, where ADH will be increased. More levels of ADH will be increased in blood. Okay. So this is about yeah, yes, you have any doubts? Geetika, Sindhu, have raised your hands. Do you have any doubts? No? Okay. So let's talk about DM now. What is DM? Diabetes mellitus. So it is a condition, there is chronic hyperglycemia, in which there is chronic hyperglycemia. Why? Due to two reasons. Okay. Either there is decrease in insulin synthesis, or there is decrease in insulin action. Okay. There is chronic hyperglycemia. Chronic hyperglycemia. That is about diabetes mellitus. So in the etiopathogenesis, we have so many types now, but remember mainly three types. The first type 1 diabetes mellitus. What is this? The problem is decreased insulin synthesis by the beta cells of pancreas. Due to some reason, beta cells of pancreas will get destroyed. Mostly the hypothesis says the autoimmune destruction of beta cells occur. So they will be destroyed. So no more cells in the body will produce insulin. This will create a actual absolute deficiency of insulin. Okay? This is type 1. Now what is type 2? Type 2 states that type 2 make what happens, the insulin will be secreted normally, but there is decreased insulin action. Insulin action. Why, sir? Why insulin is not able to perform its action even after getting secreted in normal amount? Because insulin receptors are getting destroyed. So there are no functional receptors for the insulin. This will create a functional insulin deficiency. Okay. So uh, you should start insulin only if you are sure the patient has type 1 DM. Okay. Insulin, if you start for type 2 DM, then there will be no response. Patient still lands up in hyperglycemic symptom. Okay. The third reason is there. What is the third type? GDM, gestational diabetes mellitus. We'll talk about this. What is happening here? This is a transient form of, due to high demands during pregnancy, transient form of diabetes mellitus, where there is hyperglycemia only during pregnancy. Only during pregnancy. Okay? So only due to increased demand by the fetus, there is hyperglycemia. The mother's blood contains high levels of glucose. So this is about diabetes mellitus. Okay, everybody understood the pathogenesis. So here disorder is in the glucose metabolism. Problem is in the glucose metabolism. Okay, that is the primary disorder. So which hormone? Insulin is the hormone here which is involved. Okay, insulin hormone is involved. So what are the main symptoms? Main symptoms, yes, everybody, about diabetes, the main symptoms of diabetes are P, 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 polyuria, polydipsia, polyphagia. Because of this, what will happen? Polyuria, polydipsia, polyphagia. Polyuria, polydipsia, polyphagia. Yes, polyuria, polydipsia, polyphagia. Okay. So serum sodium, serum osmolality. Now tell me, what should be the serum sodium level? Does diabetes has any effect on serum sodium? No, it will be normal. But serum osmolality, since glucose is a solute, since glucose levels are more in the blood, since glucose is a solute, the serum osmolality will be high here. Okay, this is about sodium. Now, what about urine? Urine output. Urine output here will be increased. Why sir? Why urine output will be increased? Because of something known as osmotic diuresis, meaning increased level of glucose in the urine. It will drive more water from the blood. So more water gets secreted into the urine. This is osmotic diuresis. That's why we have polyuria. That's to compensate polyuria, to compensate dehydration, patient drink a lot of water. Polydipsia. And even though glucose levels are more in the blood, but patient tissues does not get enough glucose, and that's why patient eat a lot. So polyphagia will be there. Polyphagia because the patient tissues are not getting glucose. Why they are not getting glucose? Glucose, to send glucose into the tissues, we need insulin. Insulin is not there. Either there is actual deficiency or relative deficiency of insulin is there. Okay. So urine osmolality. Now tell me about urine osmolality. Whether it be high or low, it is high because solute glucose is there. What about urine sodium? Sodium, no effect on sodium. So sodium will be normal. So should we restrict fluid? No, we shouldn't do any restriction. Nothing will happen if we do also. How should you treat this? Either you start oral drugs or you start injections. So oral hypoglycemic agents. So we have so many metformin, etc. etc. So many are there. Okay. Insulin is injectable. This is how you treat. You try to replace. Oral hypoglycemic works only for type 2 और type 1. ठीक है, ठीक है, both. ठीक है, metformin. Okay. Now, but insulin should start only for type 1. ठीक है, this is about the DM. Now, what is DI, sir? Diabetes insipidus. Why it occurs? Anyone? Diabetes insipidus. Here, there is a problem. There is a problem in water. What is happening, sir? Excess water loss. Excess water loss occurs. Excess water loss occurs from the body. Okay? So excess water loss occurs from the body. Why? There can be two reasons. Two reasons. So number one reason could be the problem is in the central nervous system, or the problem is in the kidneys. So nephron. So if the problem is central, meaning what, from central nervous system, we have no ADH. Normally ADH should be secreted, and this ADH will prevent water loss. Now ADH is not getting secreted. Why it is not getting secreted, sir? There is some damage to posterior pituitary, or there is some damage to the hypothalamus. So from here only ADH was coming. So why, sir? Why damage? Damage means what? What do you understand by the word damage? So damage might have occurred during surgery, or damage might have occurred to the head during trauma. Something might have happened and that have damaged the pituitary. Hypothalamic damage or pituitary damage might have occurred due to some brain surgery, something. So because of which no ADH is there, no ADH. So if ADH is not there, water cannot be conserved by the body. Okay. Or ADH is there, but ADH receptors are not functioning. That is known as nephrogenic DI. ADH receptors are not functioning. It mainly seen in, especially first time where it is seen, it is seen in psychiatric patients, bipolar disorder patients who are on lithium. Okay, so lithium is the causative agent for nephrogenic DI, main factor, and some genetic syndromes will also be there that you don't need to go through. See, you have to know what is the problem in diabetes insipidus. Excess water loss. So what is the disorder here? The problem is in the water body water. Also water balance will write. Okay, water balance. So which hormone is involved here? ADH hormone is involved. ADH hormone. ADH deficiency. Basically, what is it? ADH deficiency. Okay. Now tell me, what is the main symptom here? The main symptom is polyuria. And to compensate polyuria, what the patient will do? Polydipsia. That's what. These are only the two symptoms. No polyphagia here. No polyphagia. Okay. Here we had polyuria, polydipsia, polyphagia. But here only polyuria, polydipsia. Polyuria is the main complaint. Excess water loss from the body is the main complaint. And to compensate the water loss, to prevent itself from going into dehydration, patient will drink lot of water. So polydipsia is there. Dipsia means drinking. And to elaborate more, this polyuria is so severe that it can also occur in the night. So nocturia, patient will tell you she is getting up in the night just to pee. So that is nocturia. Okay. Now tell me, is there any problem on the ADH? Does it have any effect on serum sodium? No. Okay. Serum sodium will be normal. Normal, no effect. What about serum osmolality? Osmolality. Now see, excess water is getting lost from the body. So how will be the water content, whatever is there in the body, blood will become concentrated. So osmolarity will be high here. Yeah. What about glucose level? Any change in serum glucose? Yes, okay. Serum glucose, no effect, so it will be normal. What about urine output? Urine output is very high. That is only the complaint. No high will give. Urine output is high. What about urine osmolality? High output means more water in urine. More water in urine means low solute. That's why osmolality will be low. Okay. What about sodium levels? Normal, no effect. Okay, normal or low, that depends कितना water है उसमें. Fluid restriction, if you don't allow the water, the patient to drink water, anything changes, the patient might go into dehydration. Okay, so what is the treatment here? You replace the ADH. So what is the ADH is known as vasopressin. So vasopressin ka synthetic analog you give, that is known as desmopressin. You give desmopressin. Give desmopressin for central DI if the DI is central. For nephrogenic DI, thiazide diuretics can be given. Thiazide diuretics. Okay? Nephrogenic DI. This is about DI, diabetes insipidus. Everybody clear, no? Diabetes insipidus. Now, let me tell you SIADH. SIADH में, yes, sure, Sindhu. I'll repeat. See, what are we studying? We are studying this into this definition, etiopathogenesis, what is the main disorder and what hormones, what symptoms are there. Then from here all the investigations will start. Okay, serum ka investigation is this, and then we have urine ka investigations. So urine ka investigations is this. Okay, urine ka investigations. So serum में no effect on sodium. ठीक है, in diabetes insipidus, since water is getting lost, so concentrated serum will be concentrated. But here urine, since water is getting excreted in the urine will be diluted, low. ठीक है, urine will be low. Hello, am I audible? Arpit, I'm not able to see this thing. Yeah, now, yes. Okay. So yes, somebody is asking how diuretics for functional diabetes. Yeah, in diabetes insipidus, if it is a nephrogenic cause, first step is to remove the offending agent, like lithium. You will remove the offending agent. Then we can start the patient on a diuretic known as thiazide. So thiazide, why thiazides are effective? Because they have a, initially in low doses, they have an anti-diuretic effect. I know how it sounds. They should dilute urine actually, but initially in low doses, they have a paradoxical anti-diuretic effect. And they will cause this thiazide, they also cause increase in the reabsorption, especially in the distal tubule. So there is dilution of urine is being lost by thiazide. Okay, in low doses. So normally we do a combination therapy of thiazides plus salt. Okay, salts. Okay, this is how we will try to manage nephrogenic DI. Nephrogenic DI, first step is to remove the offending agent. Osmolality not understood. अच्छा ठीक है. But osmolality is nothing but focus on the solute. ठीक है. If water content is more, then osmolality will be less. Osmolality is basically solute. If solutes are more, osmolality more. If solutes are less, osmolality will be less. So now focus on here. Serum osmolality in diabetes insipidus. See what is the name? What is name? Diabetes insipidus, meaning what? Tasteless. So here urine is tasteless because in olden days they were tasting urine. No? So why urine was tasteless? Because urine contains lot of water. Water is tasteless. So urine ki osmolality should be low. This is how you remember. Urine osmolality is low because urine contains lot of water. Lot of water. ठीक है? Understood, Dr. Sim? इसका converse of this. If urine osmolality is low, urine osmolality, serum osmolality will be high. ठीक है? Okay, converse of this. Now this over. Now we will talk. We will sum up. We'll sum up very soon. SIADH, last topic, SIADH. Here, what is the pathology? What is SIADH? SIADH is a condition where excess amount of ADH is getting released. Excess ADH is circulating in the body, and it is causing excess. What will ADH do? It will preserve water. No, so excess water preservation, that is excess water retention, is happening in the body. Imagine excess water retention in the body. So why is that? Why ADH? What could be the pathogenesis? Again, the main pathogenesis could be the first one, CNS problem. What could be the problem in CNS? Due to some infection or due to some trauma or due to some surgery, they will end up, instead of damaging the ADH cell, they will end up stimulating hypertrophy of the ADH secretion cells can occur. Okay. Or some lung pathologies like small cell carcinoma of the lung. They might have a paraneoplastic syndrome where they will increase, the tumor will increase ADH in the body. Or there are some drugs, like some CNS care drugs, which you might have been familiar with, SSRIs, SSRIs, or some seizure medications, anti-convulsant drugs. Okay. So these drugs, they have a effect on ADH secreting cells, and they'll stimulate ADH secreting cells, leading to SIADH. So in SIADH, what is the problem here? There is excess water in body. Okay. The problem, excess water in body. Now, because of excess water, what will happen now? You tell me. What is hormone here? Or ADH excess? ADH excess. Because of excess water retention, what will be the main symptom? The main symptom will be abdominal pain. Sir, why abdominal pain, sir? Now tell me, okay, from top to bottom we will come. In the brain, excess water in the brain might cause headache. They might irritate, cause nausea also. In the abdomen, hyponatremia, because of hyponatremia, because dilutional, no, dilution will occur, no. Hyponatremia की वजह से we will have hyponatremia के symptoms, abdominal pain, confusion, etc. ठीक है, because of hyponatremia. So now tell me, serum sodium will be low because serum is water. Serum contains lot of water now, so serum sodium will be low. What about serum osmolality? Lot of water means serum osmolality will also be low. Okay, what about glucose? Serum glucose, you tell jaldi. Normal, because there is not a problem with glucose. Now tell urine output. Urine excess water is conserved, so ADH will not allow more urine output. So urine output will be low. Okay, low meaning concentrated urine. So if urine is concentrated, what will be the urine osmolality? High. Okay, urine osmolality will be high. What about urine sodium? Urine sodium will be high. Again, high sodium because concentrated urine. High sodium. So if you restrict the fluid, what will happen? Fluid restriction. If you restrict fluid, if you don't allow the patient to drink more fluid, what will happen? Urine output will be normal, will become normal because urine output was low, no. So if you restrict fluid, ADH will stop naturally. If ADH stops, then urine output will become normal here. So how do you treat? The treatment is fluid restriction. Or if the fluid restriction, in mild cases it will work. Or in severe cases, you would give ADH antagonist. Simple. Anybody, can anybody tell what are the ADH antagonists? Just one example. I'll be very happy. ADH antagonist, vasopressin antagonist, vaptans, vasopressin antagonist, all vaptans will come. So what vaptans are? Tolvaptan, okay, conivaptans, all vaptans, ADH antagonists. I hope we made it very simple for you. Okay, very good, very good. Call Vaptan, Prasuna, very good. Now, this is about all endocrine sum up. Okay. So some hyperparathyroidism you can read. Yes, nothing is there. Some insulin is there. Everything you can read about that. Very small topics, but main topics where you can there are chances of getting confused. This is how we summarize. This diabetes is important also in NEET PG. What is DM, DI? How it is different. SIADH. They'll give you these values. In MCQs, yes, we'll send MCQs now. See, in MCQs, we'll give these values. Urine or these osmolarity values, and then serum values we'll give. We'll ask you to identify which disorder is this, DM, DI, or SIADH, based on these values. See, in DM and DI, serum osmolarity will be high, and only in SIDH it will be low. So you remember this, and or else you just make this table, and if you look at it once or twice, you will be able to understand. Okay. So thank you everyone. Any doubts? Any doubts? Any part of this PPT you want me to repeat? Any part about bone and endocrine? Any part? Any slide? Any line? Okay. Okay then. Thank you so much. Bye bye.